Well, good evening, everyone. Welcome back to our Exam Pro weekly webinar series for the 2020 ABOG Oral Board Examinations. For today, Tuesday, September 14th, 2021, we will get right to our case list review session since that is Sundays and Tuesdays. Thanks to all of our candidates who have joined us, and particularly to Dr. Addison and Dr. O's who have already raised their hands. And we would be very pleased to work with any of you who would like to raise your hands and step in tonight and spend a little time talking about anything of interest on your case list. Let me just get rid of this for a moment. I think we're otherwise good with everybody on audio, and I've got the case list up here. So let me just get set up for a moment and we will get right to work. Let's see, I think we are going Dr. Addison first. Let's see, Agustina, I am working on getting you unmuted. If you can click your unmute for just a sec, if you can click your mute for a moment and unmute yourself, we'll get right to you. Let's see, Augustina, I'm not getting you unmuted for some reason. I keep saying yourself muted. Let me come back to you in just a second. Let's go to Dr. O's for just a moment. Dr. O's, can you unmute yourself? And we will, there we go. Hi, can you hear us okay? Hey, thanks for joining us.
Okay.
Let me get down here to, let's see, I have your case list right here. Anything particular you'd like to talk about this evening? Got everything right in front of us here.
I don't think so. Maybe
Okay.
starting with GYN.
Sure, we'll go GYN. That sounds fine. Let's see here. Great. Let us see. Can we do case number 1 on GYN?
Okay.
Just because they can always pull something off the first page. So a 36-year-old vulvar pain and a non-healing perineal lesion. I would start there. If the patient comes in with only that complaint, and this could be on your GYN or office practice case list, what would be a basic differential diagnosis that you'd be thinking of here?
So for vulvar pain, first kind of examining if there's a lesion. So precancerous, like VIN, VIA, or vein, vaginal dryness, a vaginitis infection, a sexually transmitted infection, which could include gonorrhea, chlamydia, HSV. Other things could be like a vaginal fissure, like an injury.
Very good.
Let's say I think that's everything kind of coming to mind right now. I guess also other things could be like non-infectious causes, so like psychogenic or like a vestibulitis or vulvodynia. That's what I'm trying to get at.
Okay. So if you saw a non-healing perineal lesion in a 36-year-old, how would you decide whether or not you wanted to biopsy it? Because I'm assuming we don't biopsy all the perineal lesions we see in 36-year-olds, probably only some of them. So how would you determine whether to biopsy or whether you might want to take a culture of it or a swab of it or maybe do something else with it?
So things that helped me determine to biopsy it was like the amount of time that it was present for, if it was improving or getting worse, if it responded to different treatment options, ruling out the other potential causes. So ruling out infectious causes or a fissure that's not healing.
Okay. If what you saw here was a solitary non-healing lesion of the perineum, and I'm assuming a lesion is something that's sort of an ulcer or a break in the skin or something like that, what would be your maybe your list of your top 4 or 5 things that could cause that?
So not the most common, but the most concerning would be a precancerous or cancerous lesion. Injury sustained during intercourse, inflammation.
Okay. If it's a solitary lesion, though, can you confine that a little bit further? What would be the specific things that you might be thinking of?
As far as like ulcer lesion, as far as like syphilis or HSV or other sexually transmitted infection.
Okay, sure. So given that differential diagnosis, it sounds like you're going to biopsy it. Would you do any other testing at this point while you're getting the biopsy?
Um, so yes, I would get an infection, gonorrhea, chlamydia, vaginitis, panel,
Hmm.
HSV. This patient had already had that testing prior
Hmm.
to coming to seeing me. And
Okay,
then, of
sounds good.
course, pap smear as well, making sure that her other preventative care is up to date.
Sounds good. So it looks like you did a colposcopy and you biopsied this, and it actually came back very non-specifically with chronic inflammation. How does that define your differential diagnosis any further?
So that rules out for me infectious causes or precancerous cause, which is my main concern when I did the biopsy.
Okay, so if it were a vulvar chancre or an HSV lesion, would a diagnosis of chronic inflammation rule out either one of those?
Yeah, I guess it wouldn't, that would
Yeah,
not rule out. I
yeah,
guess
no,
you may, that's a good point. You may
yeah,
see
yeah,
inflammation with an
yeah,
infectious
sure,
cause,
yeah.
but she
But
had
you
already
said
had complete STI
exactly.
testing.
So
Yeah.
that's right. So it's good, very good. That's exactly the answer you want to give the examiner. So in the setting of, because you already laid that out, completely negative STI testing and a biopsy that indicates only chronic inflammation, what would be a possible differential diagnosis now?
Um,
'Cause I'm assuming by a lesion, you're seeing something really focal. This is not sort of like a general inflammation or something that looks like sort of yeast-related chafing or chapping or something like that. It sounds like
yeah,
there's a focal something here that you're looking at.
yeah, like at 6 o'clock of her vaginal introitus had like kind of an
Yeah. Uh-huh.
erythematous lesion that kind
Uh-huh.
of had like
Yeah.
a fissure in it that wasn't going
Ah. Okay. So
away.
so fissure.
Um,
So fissure. So it could be a fissure, and I think you mentioned trauma from sexual relations or something like that.
mhm.
Um, Anything else would be on your list here?
I mean, you could think about other like vulvar skin conditions
Yeah.
like lichen
Like
sclerosis. So usually that
okay.
wouldn't be confined to that one area.
That's very true, and not likely in the inferior perineum. And also, the pathologist would be good enough to tell you that there were definitely lichenoid changes, I think, on there. So if it
Yeah.
just says
Oh,
chronic
yeah. Yeah.
inflammation,
That
less
would
likely.
be
But
perfect. Yeah.
I think you want to put in there this could be a focal manifestation of some sort of vulvar dermatitis. I think that's a good thought also.
Okay.
Anything else we should put on the list, and then we'll move on to what to do about it.
Um,
The interesting thing about this case is this is kind of unusual that you get back just chronic inflammation with negative
yeah.
STI testing. It's only a few things it could be. I would get the examiners might go around and around and around on that because if we sit in resident rounds, the stuff that always comes up is there are certain autoimmune syndromes that can actually cause ulcerative lesions around the vulva. Beset's disease associated with inflammatory bowel disease, for instance, would be one of them. And when we get down to stuff where you're not getting anything infectious and you're getting chronic inflammation, but you got a focal lesion, that's something I think they may want you to sort of throw out there just in case. But yeah, I don't
Okay.
think you have to specifically say Behçet's. I'd say that I would keep in mind autoimmune syndromes of various sorts could cause this.
Okay.
And perhaps that might actually sort of lead you into your management. So given what we had here, a very non-specific chronic inflammation, negative STI testing, how would you manage this patient then in this case, given what really lack of specific information we have about a
Yeah.
diagnosis.
So, like, interestingly, this patient, the way she was managed, she was after the biopsy was given, like lidocaine gel and
Yeah.
Sylvagene
Hmm.
ointment just to help it heal, and
Oh,
then hadn't actually like didn't follow up with me after that because her symptoms are overall improved at that
hmm.
point.
Hmm.
Um,
Good.
if it was more of like an autoimmune type condition, doing like a hydrocortisone ointment, things like that may help. I think this patient, we had tried, some of those things previously to the
Hmm.
biopsy. It just wasn't getting better.
Okay. Anything else you might consider in this case? Everything you've said, I think, does make perfect sense. But I
Um,
mean, for a non-healing lesion and sort of the lack of any specific information that identifies this as a gynecologic specific process.
mhm. um, are you thinking like ruling just as overall making sure she's otherwise healthy, ruling out other kind of systemic?
Yeah, but there's so many things to talk about there. I'm not sure.
Yeah.
When we get to this point in the exam, and you sort of, I think what you've done for us very nicely, you identified, I don't think this is clearly gynecologic. This may be something dermatologic, but there's no evidence that it clearly is gynecologic. So one of the things the examiners want to know is sort of that we understand when we come to the limits of sort of what we are able to do in our experience, and then maybe we call on other people to help us. So in the exam, it's absolutely appropriate and really encouraged to refer to other people when appropriate. So not to feel that we do not have to manage every single case right down to the last iota by ourselves. We can call other specialists.
So kind of saying, so at this point, she's still not improving, like consulting like dermatology.
There you go. Yeah, exactly. That's a great thing just to throw in there. And the examiners would be very happy to do that, because probably overall we'll get there faster if we actually bring in somebody else who's maybe more familiar with these sorts of things. And they may actually be able to figure out another way. They may have other testing to do with that. But that's an important thing to remember in the exam. When we get down to stuff where we're really in unfamiliar territory, feel free to call on other people. That's absolutely appropriate. That's what we should be doing throughout our careers. Our patients will get less good care if we try to do everything ourselves, even if we're really unfamiliar with what's going on. That tends not to work out so well.
Yeah.
So good. No, you walked through this. In this case number one, you did a really good job of working this up. You identified that from your STI testing, your examination, your biopsy, that it was not clearly a gynecologic condition or something that we commonly manage. You started trying some you did a colposcopy. It's really important. You tried some simple things to see if we could get it to heal. If not, I think the correct thing is you refer on to some other specialist. And in this case, I think dermatology is completely appropriate.
Okay, cool.
Good work. That was actually a really good case for talking about.
It kind of was a weird case, and then having that initial biopsy in the office not come back with definite answers.
Yeah. But it's good to talk about, because this stuff comes up all the time in the exam, just sort of where to go. You always have someplace to go, but it doesn't have to be someplace you go by yourself. You can actually get other people to go there with you, and that's always encouraged, actually. Good job. Eddie, thank you very much. That was nice. Let me go back and see if we can get Dr. Addison here. Augustina, hang on. I am trying to get you unmuted again. Trying, and it's not working. I may have to come back to you again in just a second. I apologize for that. Oh, there you are. Hi, Augustina. We got you.
Sorry, for some reason it wasn't working.
I'm not sure. We got you. That's actually cool. Let me get down to your case list right here. Anything you'd like to talk about this evening, since you have
since we did a GYN, can we do an OB case? And
yeah, let's do it. Sure.
Pick whichever one you like.
Any particular one that you're looking at on OB?
No, I'll leave it up to you.
Okay, sounds good. Let's see. Let's see what we can do here. Great. Case number one. Maybe we're just going to go with case number one this evening for everybody. So 20-year-old, she's that's her second baby already, 39 weeks active labor, SVD, and looks like she had really nice outcomes there. If this patient's admitted in active labor, you're called to see her. And on your examination, you identify, she's, let's say, maybe 6 centimeters dilated. You identify what is an apparent brow presentation, or possibly a face presentation. How would you begin to evaluate the situation further? What would be your sort of first steps in looking into this?
So I went in, quickly review the patient's chart, make sure she has, I'm familiar with her history, her past medical history. I go in and examine, and I feel a face presentation. I try to see if I can palpate in a suture line. And if I'm truly convinced it's a face presentation, I would proceed to counsel the patient that we might have to proceed with a C-section.
Okay. Do we have to proceed with a C-section in this case?
If it's a true face presentation, I believe so, yes.
Yeah, I think so. Let's go back to brow presentations where we started. That'll make it more interesting. So let's say it's a brow presentation. How would you evaluate and think about that?
So for a brow presentation, there is a possibility that she can deliver the baby. But from my experience, the baby comes out with a lot of facial edema, eye edema, lipedema. So I'll counsel the mom as to what I am examining, and let her know how the baby is presenting, and go ahead and continue with her management, yes, and try to expect a vaginal delivery.
Okay. Before we go ahead and commit her to labor and vaginal delivery, is there anything else you would want to know on your vaginal examination about this presentation?
In terms of the brow, if
Yeah. Mm-hmm.
whether in the position, I know where you're going for.
Mm-hmm.
I'm trying to think where you're going for it. In terms of where the occiput is in reference to the brow.
Right. Yeah. Okay. So, well,
Right.
I mean, the occiput is at the back of the head, and what we got here is the front of the head presenting. So there's another, we call it a denominator. When we're talking about a vertex presentation, the denominator is occiput, anterior, posterior
Yeah.
transverse. For a brow presentation, there's a separate denominator. For brow and face presentations, it's a landmark we're talking about. Instead of the occiput,
Yeah.
there's another landmark that we use. What's that?
It's not coming back to me. I have to look it up and
Okay.
get back to you on that.
Also, well, tell you what, instead of using the Latin or medical term, can you just tell me what part of the baby's head is the denominator in this case?
The denominator, so are you talking about the
I mean,
forehead to the,
what landmark? So with the vertex presentation, we figure orientation is occiput anterior, occiput posterior, occiput transverse. With a brow presentation, how do we determine orientation? We don't use the occiput. What's the denominator is the anatomic landmark, or the part of the baby's body that we use to determine the orientation. So for a vertex presentation, it's the occiput. For a brow or face presentation, what part of the baby are we using to determine the orientation, anterior, posterior, transverse?
I'm so sorry, it's not coming to me.
No, that's okay. It's a mentum anterior or mentum posterior, and that is actually the chin.
I see.
So
Yes.
that's right, because that's you can easily in a brow or face. That's what you got sort of sticking there. So would you prefer that this be mentum posterior or mentum anterior if we were trying for a vaginal delivery?
Mentum anterior.
Well, that would be the equivalent of in vertex and occiput posterior at OP orientation, where the back of the head is down and the front of the face is pointing up. So for a brow presentation, that would mean that the brow or the back of baby's head is on the bottom side and the chin is on the front side. Is that what you'd like for a for prognosis for vaginal delivery?
Repeat that again. I'm sorry.
So what you said mentum anterior, which means the chin is up at the top toward the symphysis pubis. It means the back of the baby's head or the brow is posterior. So it's basically a face up brow presentation. Is that what you'd like for the most favorable prognosis for a vaginal delivery?
No, that would not be.
Thanks. No. What should we go?
The chin to be posterior. You want the chin to be
mentum posterior. Good. Yes, that should theoretically 60 to 80% chance for vaginal delivery if it's a tried adequate pelvis, which it looks like it is, and if nothing else happens during labor. So a possible mentum posterior. If it were mentum anterior, how would you counsel the patient, and what would your plan for management be?
If it's mentum anterior, given that it's going to turn into a brow presentation, I will go ahead and counsel her for a cesarean section.
Sounds good. Yeah, there's a lower possibility of vaginal delivery there. If it's a brow presentation and you decide to continue with labor, what specific things would you be watching for during labor that would lead you to decide to abort your plan and just go to a C-section? In other words, what are the potential things that can happen during managing a labor with a brow presentation that would sort of obviate a vaginal delivery?
If for some reason the chin is not presenting first, but the brow is presenting first?
Well, if that were the case, it would be, be turning more toward a vertex presentation, I think. That might be a good thing.
Okay.
It means the chin is tucking. That I think might be a good thing.
So if it's the opposite of if the
Okay, yeah, now you're going in the direction. I just want you to use this is the oral exam, so you're just trying to practice using the words. So
okay, if the chin is presenting first instead of the brow, if it's rotating first.
So it's converting itself from a brow presentation to what kind of presentation?
If it's changing from a brow presentation to a face presentation.
That's exactly right. It is moving more toward a face presentation. The head is flexing more and more and more, and now that's C-section too. What else might you be watching for during labor that would lead you to recommend proceeding instead to a cesarean? With these questions, remember, one thing we're often asking about very basic stuff that actually would pertain to almost anybody in labor, but we just need to tell the examiners that we are watching for that stuff. One of them, obviously, a face presentation we can't tolerate, and we're going to go deliver. I basically I agree with you absolutely. What else would we be watching for labor that sort of can happen in these pseudo malpresentations that might, make us want to shorten labor and go do a C-section?
If I'm getting a compound, like let's say the arm is close to the face,
that's more complicated too. But I think I might bail in that situation. Yeah, you don't have to, but I might. Yeah. Anything else here?
If I'm noticing a lot of edema in the face and the lips, I'll also move to C-section.
Anything else? About the third or fourth time they ask anything else, it means there's something actually pretty basic here, and it may be just sort of universal for patients in labor. And they just want to see if you can step back and look at the bigger picture sort of thing of what else happens, when we're laboring babies and they're sort of presenting in different ways. What other thing do we run into that sometimes just limits our ability to let labor continue into a vaginal delivery?
A cord presentation, if a cord prolapse occurs.
Okay, that would be pretty dramatic. Maybe something less dramatic than that. Maybe something more common, because cord prolapses in these cases are not common.
Trying to think something basic.
Just some real basic, yeah. Just think about well, no, right. An arrest of labor. That's a really good one. Good. Now we're thinking along the right lines. Just think about, the last 10 times you did a C-section for somebody in labor. Sort of what were the common reasons why it happened? One, I think, is a labor dystocia or an arrest of labor.
Arrest or descent.
Okay, sure. Yeah, dystocia or arrest of labor in general. Yeah. Anything else?
No, I'm sorry, it's not coming to me right now.
Well, I mean, just think about the last, maybe dozen C-sections you did on people in labor. Aside from labor dystocias or arrests, what other reasons were behind why you did a C-section? The last maybe 12 C-sections you did for people who were actually in labor. What other things turned up?
Most of the C-sections were mainly just the arrest of labor after dilation and I'm sorry, I'm really blanking out.
Okay, no, that's fine. One of the things we're always watching is we do examinations on people in labor, but we also look at the monitor, right?
Yeah. Oh man, it was so basic, non-reassuring.
Yeah, exactly. Yeah. Most of these non-standard presentations do at some point have a weird looking fetal heart rate tracing, don't they? I mean, that happens with the OP kids a lot and people who are, transverse and trying to rotate. Yeah, exactly. Yeah. So I think, right. I think arrest, compound presentation, moving toward a face presentation, non-ensuring fetal status. That's basically and just remember, you can throw that out for almost any time they ask you, when someone's in labor, what would lead you to do a C-section? Vaginal bleeding, other stuff like that. Really common stuff like that. Good. Now, one of the reasons I'm sort of just throwing case number ones out here is that case number ones for most of our case lists are just really basic stuff like this. It's a completely generic white bread case here. I mean, there's nothing going on but labor and delivery, and they can make anything of it they want to. They could have made this like a deep transverse duress or something like that. So when we have these cases and they're at the front of the case list, we just have to be prepared in the exam. Don't be taken aback if they just pull this case and did exactly what I did with it. And they could make the patient abrupt during labor or something like that. It's so open that they could make anything of it. And for the first case in OB, the first 2 minutes of your exam, they would very commonly do something like that. So they're just looking at your general knowledge of OB and your ability to sort of suddenly think on your feet when they throw something that's just a little off at you. So as we practice this during the season, then you hear more and more of this. This will become actually a lot more native to us, and we'll be good at it. But I wanted to practice it a bit this evening just because it's a very common tactic in the exam. I certainly encountered it in my exam.
Okay.
Good. Augustina, thank you for going through that with us. That was actually good. Deb, do you want to take a minute? Any questions or anything you'd like to ask of it? We've got a minute or two before we move on to our next candidate.
No, I'm really glad you went through it. I was not.
No,
Because
we got there. We were perfectly okay. It's good to practice this stuff, but we got there. I guarantee in the exam you would have done okay with this case because they would sort of keep at it, and you would actually you always remember can say, I'm sorry, I'm not sure I know what you're getting to. Come back to it in a minute, and they'll go back to something else. And surprising how quickly when they move off topic, it'll suddenly pop in, and you'll just be able to name all the really common reasons why you might section somebody.
yes,
It
thank
becomes
you.
real. Thank you. Let's do. Let's see. Let me get out here for a moment. Let's see, Dr. Guardado. I think I was looking for Amanda, and then we'll kind of move down the list. Amanda, trying to get you unmuted here. There you go. Hey,
Hi,
thanks
here
for
I am.
joining us this evening. It's good to speak with you again. Let me pull up your case list here for a minute. Great. I got everything here. What would you like to do this evening? Any preferences for OB/GYN or
I
office?
guess since we just did OB and GYN, we can do office practice.
Sure. Sounds good. Anything interesting you've been looking at just this week on office that you'd like us to check in about?
I do have one case that I kind of wanted to go over. It's actually my last case on my list.
Okay. Got it right here, 33. Let's see. Okay. Let's see. Okay. So any particular questions about this? Looks like there are a few places we could go with this.
Yeah, this patient was kind of sort of all over the place. She was a 74-year-old, came in for her annual exam and then reported postmenopausal bleeding. So I got an ultrasound and subsequently did a biopsy and diagnosed her with endometrial cancer, and she subsequently underwent treatment with ONC. Separately, I had ordered a DEXA for her and it came back osteopenia. And where I practice, we have we have a ton of specialists, and it's the culture sort of any sort of thing you kind of refer to the specialist. So I ended up referring her to endocrine for osteopenia, even though it's something that we could manage, or she could be managed by her primary care. So just with this case in particular, it's like there's so many things going on. I wasn't sure kind of like if they would ask about that, or they would harp on that, or kind of what to for office.
No, I think you got this. In this case, in the generalist exam for office practice, they are not interested in everything. GYN oncology basically manage the important part of this case, and it's all GYN. They want to stick with the stuff that you do every day at your office, and the DEXA I think is exactly where they would go. So you mentioned management of osteopenia, and if you were just sort of talking this way in the examiners would see on that, and they would tell me, doctor, how do you manage osteopenia in your practice?
So the way I would sort of address it with this case, I would say, so for this particular patient, she was diagnosed with osteopenia. And even though generally in my practice, I'd recommend calcium and vitamin D supplementation, as well as exercise, especially weight-bearing activities. Given where I practice, the expectation is that we do utilize our specialists. And when I counseled the patient on this, she agreed with, she also desired to see endocrine in addition to the treatments that we discussed.
Good. So then they're still going to make you answer the question, though. So they're going to rephrase the question and say, so tell me, what is the general treatment for osteopenia in a 74-year-old?
So for this patient, assuming that according to her FRAX scan, she had no risk of a hip fracture more than 3%, or any major fracture greater than 20%, and that she did not need to go on any medications for treatment, I would start with calcium, vitamin D, and exercise.
Okay, and I think you're right about that. I'm glad that you sort of said there's no risk above the standards, that 3% hip fracture and 20%. Those are 10-year risks for general fractures, for which you're right, she would, even with osteopenia, she'd go on medication. But the reason examiners are pushing this is osteopenia is a very wide range, and they may ask you next to define osteopenia. So could you take a moment and just quickly do that for us?
Sure. So osteopenia is when you perform a DEXA scan, and your T-score is between -1 to -2.5 standard deviations from the mean.
Right. -1 to just under -2.5, because -2.5 is the threshold for osteoporosis, so like -2.4. Yeah, you're right. And that's a fairly broad range. So let's say if her T-scores were all -2.2, in addition to calcium, vitamin D, and exercise, would you make any other recommendations for her? And you did review her FRAX scores, and her FRAX scores were in an acceptable range.
I would also I'd like to assess if the patient had any other factors that would potentially be concerning for development of osteoporosis in the future, such as smoking, alcohol abuse. Obviously, this patient is menopausal, so one could potentially consider like a raloxefen if indicated for the patient. And then you could also consider doing like a basic workup for potentially secondary causes of osteoporosis. So I would start with a chem panel, the CBC, take a look at her electrolytes, and just make sure there's nothing glaringly abnormal along there.
Okay, so you mentioned secondary causes of osteoporosis. Can you name a few of those for us?
Sure. So hyperparathyroidism would be one cause.
Right.
Long-term heparin use is another one. I believe it could be commonly associated with certain autoimmune conditions like lupus or rheumatoid arthritis. Blanking, but if the patient has any sort of medical condition where they have like calcium wasting, like one of those, some sort of renal disease.
Okay, that's true. Renal disease is a really important one. There are some other kind of common ones also.
I mean, one thing would be very early age of menopause could potentially cause or help contribute.
Would you check any thyroid function tests with her?
This patient, I don't recall if I checked one, but she followed pretty closely with her PCP, so presumably it would have been up to date if it were indicated.
Okay, are thyroid dyscrasias risk factors for osteopenia?
Yes.
Yes. Which ones? Hypothyroidism or hyperthyroidism?
Well, I would have to look this up, but I believe hyperthyroidism.
Okay, I'll go with that. You mentioned you're giving her calcium and vitamin D. Why are you giving her vitamin D? Does that help with any condition that might be associated with the risk of osteoporosis?
I mean, if she has insufficient, it could help metabolize and absorb the calcium. So low calcium could also contribute to osteoporosis.
Hey, vitamin D deficiency was the other thing. I think that the big ones are hyperparathyroidism, vitamin D deficiency, thyroid dyscrasias, renal disease. And this patient has another potential one sitting right here in front of us as far as risk for osteoporosis.
For cancer?
Yeah, exactly. Yeah. Now she's a 1B, but if she had metastatic cancer or advanced stage carcinoma, that's a definitely risk factor for osteoporosis. So very quickly, and then this will be our last question. You mentioned along the way you might consider giving her raloxefen for a patient who has osteopenia with T-scores of -2.2, we said, and her fracture is okay. Why would you consider raloxefen for her? What's your thinking there?
Well, it has been approved as a potential treatment for osteoporosis.
Yes.
And it can be used for some patients who have osteoporosis and who are on the younger side, and you want to avoid starting bisphosphonate right away because bisphosphonates do have some side effects. And so for raloxifen's often used in the younger population.
Yeah,
and then
she's 74 here, though. Is that a factor to consider for her?
Not for her specifically.
Yeah. So what was your thinking about the raloxifene there? Because you mentioned that.
I was just thinking that it was probably a potential, it could help build bone density, but it didn't have as many side effects as some of the other medications.
Okay, yeah, it's a reasonable adjunct for people. That is true. But I'm not sure that there's a particular indication for this patient. But if it's in the exam, these things will just sort of slip out, and the examiners will cherry pick them, and they'll go back and they'll have a 2-minute discussion about why raloxifene and what it does and what it doesn't do and stuff like that. So when it happens, the way to handle the exam when I sort of threw that back at you, Amanda, is you can either just step up and sort of tell them everything you know about raloxefen. Or if you'd like to just say, I'm sorry, I think I misspoke here. This patient is 74 years old. I can't think of any real reason why she would need raloxefen. And see if that will deflect it. And they will be often very happy just to move on. Or sometimes you can't, and they will just say, well, tell me about raloxefen anyway, and then you're stuck. But if you do that, it's more likely than not that they'll just move on. And you can save yourself just sort of being uncomfortable for a minute or two if that's not one of your strongest medications to talk about.
Got it.
So those are ways in which you can kind of guide the exam.
Okay.
Good deal, man. But you did a really nice job with that, with the whole osteopenia thing. That was actually overall, I think, very nicely done. Pretty happy with that.
Great. Thank you.
Good work. Thanks. Let's move right along here. Let me get back out for a second. Let's see. We're looking for Dr. Nice from that. Sasha, I'm going to see if I can get you unmuted here for a moment. Oh, it did. Hi, Sasha. Can you hear us okay?
Yes, mine's actually
Thanks.
under Howard on the list, it looks like.
I was about to ask you about that because I did not see you under your actual name. I thought that might be the case. Good. I got you right here. All right. We got you. Yeah. So anything you'd like to look at?
Let's go for GYN.
Sure. Let's do it.
So we can start over again.
Okay, let's see. We'll move away from the young category. We'll do something that's like more specific and focal, maybe. Let's see here. Let's cruise down here a little bit here. Great. Can we do case number 24? Again, I'm just picking totally at random. It just sort of dropped up here. 33-year-old IUD strings loss failed in-office removal. So you did a hysteroscopy with IUD removal. If in this patient you are doing exam, her IUD has been in, let's say, for 5 or 6 years and is due for removal, and you can't find the strings, you search in the endocervical canal, and you still can't find the strings, what would be your next step in sort of evaluating how to remove the IUD?
First, I have them get an ultrasound to just confirm that it's actually in the endometrium.
Good. If the ultrasound does not identify an IUD within the uterine cavity, what would you do next?
Before I even got the ultrasound, when she was there for her first visit and I was looking for the strings, I would make sure I got a thorough history to see if I had a high suspicion that she passed it, or if she, had seen it before her office visit. Then I would get the ultrasound and escalate from there. And if the ultrasound was negative, then I would move on to a pelvic x-ray, abdominal and pelvis x-ray.
Got it. Good. Okay. If you do your pelvic x-ray and the x-ray identifies the IUD in the mid-left aspect of the abdominal cavity, kind of tucked over toward maybe about the mid portion of where the colon would be on the left, what would you do at this point?
I would tell her that it looks like the IUD has migrated or perforated and is no longer in the endometrial canal. So I would think that it would be futile to move forward with any type of in-office removal. And then I would discuss with her a diagnostic laparoscopy as well as the removal of the IUD. Typically in our institution, we try to have general surgery on standby as well, to just in case, on the off chance that it could be embedded in an area that we don't feel comfortable operating. And I would also consent her for the possibility of a hysteroscopy, and make sure that that way, if we do the laparoscopy, and we would have obviously the C-arm available as well to do an operative discovery of if we're getting closer to where it's going to be, if it's shifted at all. And then also, if we didn't see that, I would like to make sure that I would consented her, since she's getting anesthesia, the possibility of doing the hysteroscopy if we needed to, although I think it would be very low returns, but you always want to make sure to over consent so you have the capabilities to do it if you feel like it is needed.
Sure. No, that's fine. But I think we both agree the IUD is clearly outside the uterine cavity.
Yes.
So you mentioned the C-arm. That's what I was coming to. How does the C-arm help you in this case?
Because we could do intraoperative x-ray if we are looking in the area that it looks on the previous ultrasound that we've seen it, but then it doesn't. It seems when we're intraoperatively, we can't see it where we would expect to. We could do an intraoperative x-ray to ensure that it hadn't moved since our last x-ray. Obviously, you try to get them into the operating room as soon as possible, but there is always a chance that it could have dislodged.
Good. Okay, so that's good. That's where I wanted to go with this case, because these laparoscopic removals are difficult. So let's say you're doing your laparoscopy and you go look and you can't find the IUD is not where you thought it would be based on that flat plate X-ray. And you bring in your C-arm and you do sort of an AP view with your C-arm, and your C-arm shows the IUD being right where the X-ray showed that it was, but you're not seeing it. What would you do at this point?
So I think at that point is when I would have the general surgeon help me run the bowel, because it could obviously be hidden there.
Yes,
So I
that's
think
true.
that would be the place
Can
where I
you
would go
can
next.
you use the C-arm to help you though?
Mhm. Oh, we could
Can the
do,
C-arm assist you?
and we already did the AP. We could
Yeah,
do a lateral.
you could do a lateral. Exactly. How does that help you in this case?
It gives us more of a 3D
There
idea of
you
where
go.
it could be
Yes,
versus
exactly.
just the 2D flat plate.
That's that the examiners just want to hear you verbalize that, because these things are tricky. You're working in 3 dimensions for a small object in a space where there's just all kinds of stuff in there, and it's easy
Yeah.
for them to hide. But you can rotate your C-arm under fluoro, and you can actually it's like kind of getting a 3D CAT scan of it. You can just rotate the C-arm, and you can actually watch in real time and sort of see in 3 dimensions sort of how deep in the pelvis it is and how lateral it is. And if you have a laparoscopic probe in there as a stable marker, you can actually then you can localize it in 3 dimensions very easily. So you can actually just do it under fluoro. That's exactly right. If you finally find the IUD and you find that it is enmeshed in the omentum, how would you manage that?
If that were the case, I mean, usually we would be double scrubbed at this point with the general surgeon for having that hard of a time to locate it. But if
Sure.
it's distal, we could use a ligature and actually try, and even the laparoscopic scissors, and try to dissect it out, obviously trying to avoid any large vessels that are running through there, because again, we don't
Yeah.
want those little arteries to retract and bleed in the omentum. But that would probably be one of the better case scenarios, it being embedded in the omentum.
Mhm. Well, I
If you
think
remove that,
you're referring it to being buried, maybe enmeshed in the very distal aspect of the omentum. If it's
correct.
sort of
Yeah, because I would think that since it'd be
if it's
low.
yeah, yeah. If it's about a third of the way up the omentum, what would you do in this case?
Well, you always worry about interrupting any vasculature.
Yeah.
So at that point, since it's not emergent, I wouldn't feel comfortable going outside of my scope. I would defer to general surgery, who operates in the area more frequently.
Good answer. That was exactly the right answer in this case. So we don't generally operate on the omentum unless we're oncologists, and I don't think any of us have actually pulled an IUD out of the middle of the omentum just yet in
No.
our careers. Certainly not if you're just sitting for the exam. So, do we have to take out the IUD if it really is completely enveloped in omentum? Do we actually have to remove it?
If it's a copper IUD, yes.
Okay, great. Let's say it's a Mirena.
Technically, no, but I would have
No,
that conversation with the patient beforehand,
sounds good.
uh,
Sounds good. Okay.
because
Yeah.
obviously I always like to know like how aggressive they want us to be in the
Yeah.
operating room.
Yes. True. Why do we have to take it out if it's a copper IUD? That'll be our
Because
last
it
question.
works by direct inflammation, and
Yes.
so it's going to be more likely to be irritating, and
Yes.
the body's going to try more aggressively to wall it off, and she's more likely to have long-term issues with
Agree.
it.
I think there's more of an issue with eventually with maybe getting bowel adhesion involvement or something like that. I agree. Yeah. And as to the question about whether it has to be removed, I don't actually know the answer to that myself. I think it's reasonable that you may not need to if it really is completely enveloped in omentum and it's really sort of walled off and protected. If possible, it's nice to remove it, but I think you gave exactly the right answer. They're pushed this case to something that probably none of us will ever see, and it's completely outside the scope of what we usually deal with. And it's exactly right. You very appropriately had a general surgeon along with you. You would defer to the general surgeon for management in this case, because this is really outside the scope of what we do in gynecology. And the examiners would want you to go exactly the way you just did in that. That's right. We know our limits and we know when to step back and to have somebody else step in and help us.
Am I allowed to ask a question that's not on this case, but the
Yeah,
previous
sure.
case you were asking a candidate earlier tonight
Yeah, sure.
about the
Sure.
OB presentation?
Oh, yeah,
So
right.
if it's face presentation, you want mentum anterior, and then if it's brow presentation, you want mentum posterior. Is that correct?
I think that is correct. I'm going to have to go look that up. I think that is correct, but I have to check that.
Okay.
Let me check that. I will be back with you next Monday. I'm going to make a note to check that. We're going to do structured cases next Monday, so I will check on that and I will get back to you. Good. I think that is correct, but I don't want to commit to that just yet, so I will check it.
Okay, thank you.
Nancy, good. Thank you very much. That was nicely done. Let's move right along. We get a couple more of our candidates in before the end of the evening here. Let's see. Dr. Kidd. Jennifer, I'm going to try and get you unmuted here for a moment.
Oh, I just have a question, actually.
Yeah. Oh, sure. No, go ahead, please.
So I was looking up that thing about the mentum. It's actually in the pearl of excellence, it says the opposite. It says mentum anterior occurs in 60% of face and deliver vaginally. So I was confused.
I will check that. I will check that and let you know. I'll actually pull up William. I'll look at it just to be sure. Thank you for bringing that up for us, though.
Nope.
Let's do maybe Dr. Hammer. Carissa, I'm going to see if I can get you unmuted also. There we go. Hey,
Hi.
Carissa, can you hear? Hi. Let me
I
get
can.
your case list up here. Let's see.
I think I only submitted the OB. I wanted to try OB.
That's okay. Of course. Got you right here. Anything particular on OB that you're looking at that we should be checking into tonight?
No, I just need some practice with my OB.
Okay, sounds good. Let's see. Let's see what we got. We got a total of 15 cases. Let's go maybe to something that we haven't talked about before. Great. Can we talk about case number 13? Right here,
Sure.
under hypertensive diseases. So this is a 19-year-old. You've listed her as a teen pregnancy, which technically she is. If we think about the category of adolescent pregnancy, when this patient presents for her first obstetrical visit, let's assume she actually comes in somewhere in the first trimester. If you identify her as being an adolescent pregnancy, are there a particular set of concerns or risks for her that you have for a pregnancy categorized that way that you'd want to talk with her about, or that you could list for us?
Yeah, so when she initially presented in pregnancy, for all my patients, including adolescent patients, I always address first if it's a desired pregnancy, if they're presenting early enough in their pregnancy. So I think that's where I would start with anybody, specifically with adolescents or teens. And then if it's a desired pregnancy, moving in a different direction than if it's undesired. But assuming it's a desired pregnancy, I would give the same counseling I'd give to all my initial prenatal visit patients, and my same prenatal panel would be given to the patient. But pregnancies at a young age do additionally have social implications, specifically with school, if they're in high school still, and can be linked to increased risks for depression and dropping out of educational curriculums or schools too. So I would make sure I've addressed those things with them and understand more about their social support system for the pregnancy and after.
Okay. As far as medical risk to a pregnancy, is an adolescent who is pregnant at higher risk of any particular things during pregnancy as maybe someone who's a healthy 29-year-old?
Yeah, actually, what happened to her of her hypertensive preeclampsia specifically, it's the extremes of ages. So advanced maternal age, but also the early ages that are at increased risk.
Anything else that you'd list as sort of a general increased risk in patients who are just adolescents when they become pregnant?
They're at risk for, I believe, preterm deliveries, but I can't confirm that.
That is true. That's actually very important. Yes, that's true.
Yeah, so preterm deliveries came to mind. The hypertensive disease we'd mentioned. I believe which is poor follow-up with prenatal care in general. And then afterwards, postpartum, they're at high risk for a short interval pregnancy, again, unintended pregnancy. So I'm very, sorry, go ahead.
Yeah, as far as risk during a pregnancy, anything else you should think of? We've got some good stuff going there. So prematurity and preterm delivery, hypertensive diseases of pregnancy. Anything else? Just as far as real general stuff.
I'm sure there are others, but nothing else is popping into my mind right now. I'm drawing a blank.
Okay. Would you be concerned about any particular risk of loss of the pregnancy at any particular time during the pregnancy in an adolescent as compared with a more well-developed adult?
I don't believe that there are increased risk for first trimester losses, but but potentially at a higher risk of going to post dates or having a stillbirth at post dates.
Okay. They should be at increased risk in all 3 trimesters. There would, depending on sort of where they are in the adolescent spectrum. Certainly, with younger, there's a higher risk of loss, especially if their sort of whole HPO axis is not as well developed. Definitely increased risk of late-term fetal demise, especially in teenagers. Potentially increased risk of mid-trimester loss. So one of the easy things to use in the exam, if you need to, if you're talking about any significant medical condition that complicates pregnancy, is it's fairly likely that there is some degree of increased risk of loss in all 3 trimesters. That would be somewhat true of someone who comes in as a hypertensive in pregnancy, as a diabetic in pregnancy, autoimmune disease, renal disease in pregnancy, virtually anything. You could say that and get away with it in the examination. It would in general be true to at least some extent in each of the trimesters. So that's an easy thing just to fall back on.
Good to know.
Good.
Yeah.
You said going post dates. Any issues with sort of growth of the pregnancy? Would you have any particular concerns there?
Well, since they're at risk for preeclampsia and other things that can be related to placental insufficiency, I would be concerned that they would be more at risk for IUGR.
IUGR, I think that too. Good, agreed. So based on that, if they asked you a simple question like, so how would this patient's prenatal care be different from maybe somebody who's 30 years old, as far as sort of how you're conducting your prenatal care and how you're observing for these risks? How would you manage your prenatal care differently based on the particular risks that you just told us about?
Yeah, I think it may include more in-depth counseling on their increased risk given their age, and also potentially increased monitoring or ultrasound monitoring if the fundal height wasn't within the 3 centimeters that I expected it to. And I would consider even antepartum testing for them, especially if they were getting near 40 weeks or past 40 weeks.
Okay. Right. Anything else? That was nicely, I think, put together.
I detailed an anatomic survey that would be similar for others, but I would probably try to do that a little earlier for them, and potentially because they have additional increased risks. I'm trying to think.
Good.
That's what I've got so far.
Okay, no, let's go with that. You stepped briefly into postpartum, just as we're wrapping up here. Any particular postpartum risks that you're concerned about for her, that for maybe higher than for other people?
Yeah, I'm at risk. I'm concerned postpartum for postpartum depression. I think she's at high risk for that. With her hypertensive disease for postpartum eclampsia, but also at high risk for an unintended short interval pregnancy.
Good.
So those are the major concerns that I have for her postpartum.
Regarding her risk of postpartum depression, then, was there any particular management that you would recommend or that you'd plan to do with her based on that concern?
So based on that concern, I think during the pregnancy, I would address that concern with her as well, understanding her baseline, if there's any history of mood disorder or depression in the family, and have a good understanding of her support group at home, how she's going to raise the child, who's going to help her, if financially she has been helped to do this and feed the baby as well and go to school or whatever else she has happening in her life. And I can connect her with social work at that point or psychiatry at that point before we even get to postpartum, and have a plan in place. And then postpartum, immediately postpartum, we routinely monitor for depression with an EPDS score, which is, and then we would do that again at her follow-up visit. In that circumstance, I would probably want her to follow up a little closer than the 6-week follow-up. I'd probably have her come 3 to 4 weeks after delivery at least.
That sounds terrific. That's very nicely done. I think it's exactly it. The examiners are just interested in hearing where you'd go with that. Some candidates might actually sort of stray into, would you actually just put her on medication, after delivery prophylactically in an adolescent? I don't think that's actually the greatest idea. I think your idea for heightened surveillance, having some degree of behavioral medicine support for her during pregnancy, because situational issues and mood disorders are fairly common in adolescent pregnancy, and looking ahead for and just having very careful surveillance and being proactive about postpartum management, I think is exactly the way to say it. And they're just, and if we took any other 5 candidates here, we'd get sort of somewhat different discussions on it. I think you were right down the center line of what examiners kind of would be comfortable hearing. I think that's nicely done.
Great. Was there something else that you were looking for during pregnancy from management?
There was no, and there are never minor things we could think of. I think you actually wrapped up the list very nicely.
Okay, great.
No, I think we're good there. Good. Let's see. I think we might have some candidates with questions real quick. Dr. Jawed, I think. Asra, I'm going to try and unmute you for just a second. Did you have a question for us?
No, it's just volunteering.
Oh, okay. Thanks. Hang on. Let's see. Well, here, let's actually just for a second, let me check. Let's actually do that real quick. Let's go ahead and let's grab you and get you unmuted again for a minute, and let's have you volunteer.
Okay.
Back here. Let's see. You were down a little bit here, I think. There you are. There you go. Pull you up. All right. You have the floor. Anything you'd like to talk about? Your entire case list is open here.
No, whatever you think you want to go with.
Okay, let's see. Can we do GYN? This actually might be our last discussion for the evening. Let's just hit something in GYN here for a minute. Let's see. Let's see. Let's see here. Lots of stuff going on here. Let's see. Let's see. Got it. Can we talk about maybe case number 15? Just some PAP-CIN stuff to look at for a few minutes.
Sure.
Let's see. So this is a 66-year-old with a high-grade cervical cytology, and looks like you identified on colposcopic biopsy a high-grade lesion, and your ECC was insufficient. In a case like this, and in general, when you have these sort of things going on, we've got a high-grade lesion and you did find something on your colposcopy, how do you decide whether you are going to recommend to your patient having a leep or a conization of the cervix?
Right. So ideally, I guess it depends on your comfort level with a conization, I guess. My comfort level is a little bit more with leep. So I did counsel her that we could do the leep, and if that came back with positive margins, then there could be a discussion about doing a cone with possibly someone that would be willing to do that, such as the gyn-onc, or even referring her initially to gyn-onc to begin with to do a cone instead.
Did you consider her referring her directly to GYN oncology to have them do a cone instead?
I did do a, I guess, bedside consult, not necessarily a formal consult, and the gyn-onc that I work with recommended going ahead and doing a leep initially, and if there was any further concern, then we could do another excisional procedure after that, possibly, if there was positive margins.
Okay. Are you aware of any particular ACOG level recommendations on when, under what circumstances we should probably prefer a cone to a leep? Anything that's been published by ACOG in that regard?
No, I'm not actually aware. That would be something I would need to look into a little bit further.
I would look into that for the exam, because every time they issue the practice bulletin on PAP and CIN stuff, there's always a box, and it's usually on the third or fourth page. There are two boxes in there. One is when you do an ECC, which is most of the time, and the other box is when you should do a cone rather than a leep. So the examiners, I think the examiners would be interested in this particular case. So she's 66-year-old, and they might say, can you tell me about any particular factors in a 66-year-old for which maybe a cone might be preferable to a leep in this case? Any particular anything you know about how a 66-year-old cervix is that might make a conization maybe a more adequate procedure in this case?
Right. So usually, postmenopausal cervixes are short and more flush to the posterior vaginal canal, as well as they're usually stenotic cervixes. So.
Okay. So how does that lean you more toward? Are you talking leaning more toward leep or more toward cone in that case?
I would be leaning more towards a leep in that case.
A leep. Good.
Mhm.
Anything you're aware of as far as sort of a postmenopausal woman's cervix for which maybe a conization would be preferable to a leap? Any particular feature of how a postmenopausal woman's cervix is constructed?
I'm not sure I understand the question.
Oh, okay. Well, compared to a 36-year-old, is there anything about a 66-year-old for which maybe a conization is better for both treatment as well as diagnosis than a
Oh,
leap?
I think what you're maybe trying to get to is where the transformation zone might be.
Yes. Yes.
Okay. Right. So transformation zone postmenopausal female is more in the inside of the cervical canal versus
Yeah.
you can, access it a little bit better in
Yeah.
non-menopausal patients.
Right. Yeah. What the ACOG practice would say that in a menopausal woman, a cone is preferable for exactly that reason. The TZ is farther up the canal, and you need to get sort of deeper sampling. When a conization does a better job than a leap, you usually have more control over that. So in this case, what you'll be faced with in the exam is we'll need to defend this case in which you decided to do a leap rather than ECC, and it goes a little bit against what's the standard party line from ACOG. So let's talk for a minute about how we'll defend this then. So is there any other information that you can tell me that you got from this examination which really made you feel that you'd be more comfortable with a leap, given that we cannot rely on the ECC because your ECC was insufficient, and that's the weak point in this case. But I think we can develop a good defense. Anything else you learned from your exam and your couple in this case that led you to feel more comfortable with a leap?
I think going back to the fact that she had a short cervix and her cervical os is very stenotic, which is probably why in office my ECC was insufficient.
Okay. Was her colposcopy adequate or inadequate?
It was adequate.
It was adequate despite a stenotic cervix. That's good. Tell me about where did you see the lesion on colposcopy?
That I think I would have to take a look again at that case to be able to.
The critical question I think you want to bring up to the examiners is, were you able to see the entire dysplastic lesion with your colposcopy or not?
Yes.
Yes, that's the answer I was hoping you were going to give me. Good. So you had an adequate colposcopy, which I think means you thought you saw the transformation zone, and you could see the entire extent of your lesion in this case. And she had a short cervix. That sounds to me like a pretty good defense for maybe going against the grain and doing a leap rather than a cone in this patient. If I were defending this case, I would say to the examiners, well, ma'am or sir, I understand that generally, for the reasons we've discussed, a conization is preferable to a leap for deeper sampling because the transformation zone is fire. However, in this case, I did have an adequate colposcopy. I could see the entire lesion. It was exocervical, and I biopsied it right there, and I got the diagnosis. And her cervix was short, and I was definitely concerned about sort of the risk of complications of doing a conization. So in that case, I opted for a leap with a separate ECC.
Okay.
How's that sound? I think
that sounds pretty good.
And I mentioned this for all of our candidates, now's the point where early in the season, we want you to start to becoming very careful, very comfortable with your cases and really study it and vet it. And as you go through it, you're going to pick up things like this, or somebody's going to be helping you or working with you, and they're going to point this out to you. And rather than feel like you're going to be torpedoed by it, we can develop a defense of most things. And the defense is sort of going back and looking for what in this case can you use to buttress your argument for what you did. It's really having a debate with the examiners, and you have good ground to stand on. Adequate colposcopy, lesion entirely seen, short cervix. Now, if you present that to an examiner, they would have to agree to you that a leap is an adequate, reasonable option in this case, and you've won your argument. But the caveat is you did do a separate ECC and you got adequate sampling, and it looks like you documented that in your pathology. So you got this case down. You're okay. If they bring this up, I would want to be one step ahead of them and say, now, I recognize that usually we do a conization. However, interestingly, in this case, I did a leap. And then you'll tell them why you think it's interesting, just with the stuff that you just brought up about how you evaluated this patient. And this case will be actually then one of the strong points on your case list.
Well, thank you for discussing that, because I didn't even realize that.
No, this is we want you really looking at your case list, sort of talking with it at home. Have people start to sort of do little brief mock orals with you, just face to face. People will start bringing this stuff up to you, and that's how you find the little places in your case list that you can plan for now, so that you don't find it for the first time in the examination. We want, by the time you get to your exam, we want to have all that stuff done with.
Wonderful.
Good work, Ashma. Thank you. That was actually a really good case to finish up with for the evening. We do have to stop because they're going to shut ours down in a few minutes. Thank you, all of you, for tuning in with us. We will be doing, of course, structure cases on Wednesday. I think I'm doing structure cases with you again next Monday. Thank you all for joining us. Remember, you can go back and check all of these as podcasts on the Exam Pro website. I will check into the brow and face presentation orientation. I'll bring that up first thing on Monday when we get together next. Thanks all again for joining us. We will sign off. Have a really pleasant rest of the evening.